All right, welcome to another educational session on nerve surgery through the AANS CNS section on disorders of spine and peripheral nerves. My name is Jared Pisapia. I'm a neurosurgeon at Westchester Medical Center in New York. I'm joined by my colleague Elias Rizk, a neurosurgeon at the University of Texas at Austin. We're very pleased to welcome Justin Brown for discussion on nerve transfers and spinal cord injury. Dr. Brown is a neurosurgeon with a strong focus on restoring movement following trauma and paralyzing injuries. He collaborates closely with doctors at Massachusetts General Hospital and the Spaulding Rehabilitation Network to lead a comprehensive paralysis center. So Dr. Brown, thank you very much for taking the time to speak with us today.
Sure. Thanks for having me.
Thanks, Dr. Brown.
Right, so we'll just give a little bit of background and then can go into some further discussion. But each year, spinal cord injury affects about 250 to 500,000 individuals worldwide. These are usually young adults, and these can be very devastating injuries. But fortunately, there's an option of nerve transfers, so we'll be focusing on that today. And so just to start off, Dr. Brown, can you give us just a brief overview about what is a nerve transfer?
Sure. Yeah, so nerve transfers really have changed the way we manage a lot of nerve injuries now. And it's the idea that we can take a nerve that we have good control of and cut it and transfer into the paralyzed nerve. And sometimes that's a better source or a better way to get axons to the target more quickly than grafting or going back to the original source of axons that was disrupted. And so in the picture here, you have your red nerve there, which is the normal functioning nerve. We always want one that has redundancy so that when you take it away, you're not losing function or impairing the patient in any way. And here it is running immediately adjacent to an important muscle that's paralyzed in green. And so if you cut the red one and the green one, you suture it too, you can see there's a very short distance for those axons to grow before they reach the muscle and restore its function. And that's really the ideal scenario for a nerve transfer. It's close to that target muscle, we don't lose any function, and we gain recovery in a short period of time.
Right, perfect. And in thinking about timing, can you talk a little bit when we move now to spinal cord injury and nerve transfers? How does timing change depending on what level of muscle you're looking to reinnervate? In other words, how does this upper versus lower motor neuron injury come into play here?
Sure. So this is kind of a tricky topic when you're talking to folks dealing with patients with spinal cord injury, because we think of spinal cord injury as being entirely upper motor neuron. And true, the vast majority is an upper motor neuron injury. Everything below that site of trauma is what's listed there as a damaged UMN. All of that area below is going to be paralyzed by upper motor neuron injuries. And in those, the muscles, of course, are maintained. If it's a complete injury, they're only going to display spasticity. But at the site of trauma, the gray matter within the cord, which is actually the most vulnerable portion of the spinal cord, what's called damaged UMN. Anyhow, the part that's grayed out there, which damaged lower motor neuron, the cell bodies in there, when they get crushed, and they're quite vulnerable, they're going to lose their peripheral process. So the motor axons within the peripheral nerve are going to undergo Wallerian degeneration. The associated muscles, which are often in the forearm and hand, are going to degenerate the same way they would in a brachial plexus injury. So we have really a very similar time schedule to nerve injury for the muscles that are specifically innervated by the motor neurons at the site of spinal cord trauma. So if you think about the neck, it's the C3-4, C5-6 bony area, which is the most common areas of damage, and the cord just beneath that is where those lower motor neurons are getting damaged. So often it's the forearms and the hands, and you lose the intrinsics, and they really waste away, and the forearms get quite bony in these patients.
Excellent. And when you're selecting patients, as we mentioned, a lot of these injuries occur in younger patients, but do you have an upper limit, an upper age limit to which you'd offer nerve transfers for a spinal cord injury, or is it more case specific?
It's kind of case specific. I have to say, when I get into elderly patients, I often am moving towards tendon transfers, simply because of the time it takes to recover the nerve injuries. You know, it's or the nerve transfers. There's going to be a number of months before we see anything. And then the amount of feedback and learning or retraining it takes with nerve transfers tends to be sometimes a little longer than with the tendon transfers. So the older patients, those who are not going to engage aggressively in therapy, sometimes the tendon transfer is a better way to go than a nerve transfer.
Okay, all great points. So if we move on towards thinking about surgical options, when you have a patient with a cervical spinal cord injury, what are some of the priorities that you're thinking about in terms of restoring movement?
Sure. So the list that you have there is quite good. Most of the patients we're dealing with have wrist extension. We do occasionally get those that don't even have wrist extension. That becomes a little bit of a tougher reanimation. But if they can flex the elbows and they can extend their wrists, then at that point, we're going to restore finger extension and finger flexion. As far
Okay.
as the functional tasks, the lateral pinch is the priority. So we always want everything, and the patients will tell you that they want everything. They want all five fingers to open, they want all five fingers to close. But what they're going to use on a daily basis is the thumb making connection with the side of the index finger. That's going to be used to pick up the phone, to use the utensil, to use their catheters, operate their chairs, and so forth. So that really is the number one priority, with a grasp being a far second. Grasp getting your hand around a cup or something else. So if you can just achieve a pinch, that's a big win for these patients.
Yeah, that could be a life-changing um, thing for a patient like that with injury. How about how do you use the international classification for surgery of the hand and tetraplegia in your approach to this?
We do what it always helps you understand sort of what to expect in the arm. So, and there definitely are exceptions to these rules, but in general, based on that system, if somebody comes in and they have strong pronation, so the pronator teres is working, so we have an international classification grade 4, every one of those muscles above it should be preserved and functioning well. So you should have the ECRB as well as the ECRL as well as the brachioradialis and the supinator, which isn't on the list. All of those should be intact. So it helps you know with a very cursory examination, if he has strong pronation, all of those are available. And so now we know what we have to work with to reconstruct the hand.
Right. Right. And how about preoperatively? Do you check an EMG on patients before considering nerve transfer?
I do. I check EMGs really on everybody. And the importance of the EMG in these is sometimes people don't follow the rule book here, and everything we're stealing has a backup agonist. And so if somebody presents and they seem to have very good wrist extension, it's hard to know how much of that is the ECRL and how much is the ECRB. So it's nice to put a needle in both of them and know that they've got a similar complement of innervation. When you're looking at supination, the biceps really does a wonderful job, even in the elbow extended position, of supinating the forearm. And so to put a needle in the supinator to make sure that's a well innervated muscle before doing the transfer is important.
Right.
You will often find that stuff out in the operating room when you stimulate the nerve branches, but we sure like to know before we get in there.
Yeah, no, it sounds like the EMG does provide at least complementary data to the exam and can enhance some of those findings.
That's right.
Comment a little bit more on the EMG and the value of CMAP over, just fibrillation changes on the EMG? Do you rely on the CMAP numbers a little bit more, knowing how, it can lack some sensitivity on the
Yeah,
EMG?
so I don't use much CMAP, and the reason is in the forearm, all of these muscles are all overlapping each other quite a bit. And so when you see a CMAP response and you're hoping you're looking at finger extensors or something, you don't know whether that was the ECRL or the finger extensors or the ECU or the supinator accounting for that response. And so I'm very dependent on accurate needle placement. So using ultrasound to guide the needle into the muscle of interest and then having them generate that response and actually have our guys count the number of present motor units, and greater than 5 or at least 4 is what we want. The higher number, the better. But if you get under 4, you start really risking that you're not going to get a good outcome.
Thank you.
And is that what you consider a quantitative EMG?
That's right.
Is that okay? And how about transcutaneous muscle stimulation? Is that something that you're also checking before surgery?
Yeah, so for the patients that are chronic, and a chronic in this population, I would say is greater than 15 to 18 months. When you get past that, or definitely in the many years out, I would tell the patients, the best that I can do is what I can generate with the stimulator. So no matter how good that donor is, when you're into the chronic period, all you can get is what's been chronically preserved by the axons below level. So the simplest way to do it is to use the same stimulators that the anesthesiologists use. They're trained for. I probably have one that I've stolen from them in the room here. I don't see it, but I just put those over the muscle bellies, and turn it all the way up. It's quite uncomfortable, but then you can watch the fingers spring into the open position of push on them and say, hey, if I've got about an MRC of 4 on that, that's the best we can achieve, is you're going to get an MRC 4 with a good nerve transfer. If they just barely open up, then we say we're probably not going to hit a home run with this transfer.
I see. So that could be helpful for, I guess, prognosis and decision making
in the chronic period,
Yeah,
for sure.
Patients. Okay. All right. I know that, every case is a little bit different. Like you said, not everything follows the textbook, but maybe just in terms of general approaches, can you talk a little bit about your approach for repair at different levels of injury? For example, maybe a C5 injury starting out?
Sure. So actually, I'm going to start low and I work my way up. So a C7 with pronator teres. I prefer to use the pronator to close the hand, so pronator to AIN, and then the supinator to PIN to open it. It's just easy to learn, and it's a very simple, straightforward transfer. If you go a little higher, you get to C6, you're going to lose that pronator quickly, and then we're going to move to the ECRB. So wrist extension closes the hand, and then supination opens it. A number of our patients were C5, so you don't have powerful wrist extension, and then the next nerve is the brachialis. The brachialis can work very well, but there are cases in which some patients have trouble separating because the remaining biceps both supinates and flexes the elbow. So we have some patients who will co-contract extension and flexion when you use the supinator for finger opening and the brachialis for finger closing. So it's not my favorite, but we have had a lot of successes with it.
Okay.
And another reason, I guess you got the picture up there for us, is a lot of folks have been using that, what's kind of like a reverse Oberlin in that picture on the right.
Mm-hmm. Yeah.
And the problem with that reverse Oberlin is there often are interconnections, and see if I can do my annotate, but that little circle in the middle there shows that by the time you get up to the level of the brachialis branch, if you're going to transfer that into the fascicle that's AIN, there is a lot of interconnection with the rest of the median nerve. And that means that all of the axons you're transferring in aren't going to make it to target. And some of these spastic axons that you don't want are going to remain in the target. So we get a weaker, and I did a number of those at the beginning, I have a much weaker grasp with that transfer. That's why I've gone to a graft now. So I do a 2-stage graft. We put in a MABC to the brachialis, and then 4 to 6 months later, I connect the other end to the AIN. And that's, in our hands, has been a better or more successful transfer for us.
I see. Okay, so really it's the interconnections at this more proximal level that can decrease the yield of your transfer.
That's right.
Okay, because I know some people have talked about if you have a lower, if your injury is, I guess the muscles you're trying to reinnervate are below the level of the spinal cord injury, that lower motor neuron is still intact. In other words, you have more time to get there, but you're not so worried about the time. It's more the interconnections here that are the problem.
Correct. Yeah, it's not the time at all. In fact, that's why when we do the graft, I'm not worried about that at all. I've had them with the graft and come back 12 months later and still hook up the other end because the lower motor neuron's intact and the target muscles.
Perfect. Okay.
You can take that little AIN fascicle and tease it away and cut all those interconnections all the way up. The problem with that is by the time you get up there, the pure AIN fascicle is probably 1/2 to 1/4 millimeter, and the brachialis is about 2.
I see.
And so making that size match for repair is really technically challenging.
Yeah, yeah. And just touching on the technical aspects of this, I know there's a lot of variation in how people do a coaptation. And any pearls in your experience how you actually will coapt the nerves, whether you use suture or not, fibrin glue, any kind of nerve wrap afterwards?
Well, I'm kind of a belt and suspenders guy. I do more than the average person. So we use these little nerve tubes, and I slide it over. Then I repair the nerve with 2 to 3 sutures. Then I slide the tube back over and suture that to the epineurium on both ends.
Okay.
The reason I do that is I like to let these patients use their arms immediately.
Okay.
And that's one of the biggest preventers of patients engaging these procedures is if you tell them their arm's going to be tied up for a number of weeks, they just won't do it. And so it's a real sales pitch for me to say you're going to use your arms just as you did beforehand. So when they move it around for something to hold tension, you don't want those sutures at the site of the axon crossing because that's the most friable part of the epineurium. If you use the tubes and suture it about 1 centimeter away from the cut ends, that holds much better, and I trust it more.
Okay, excellent, excellent. How about, I know another common transfer for spinal cord injury is trying to recover elbow extension. Can you talk about some of the different, or the main approach here, axillary radial nerve, about different options for approach, whether posterior or anterior approach?
Yeah, I use anterior for this every time.
Okay.
Posterior makes it a little bit of a tougher reach, and anterior, it's really quite easy reach once you get this down. When I first started doing this, I would actually go through the middle of the plexus and reach to the posterior cord and pull it up through, and found out later on that you can sweep the entire plexus up and just go beneath it, and then you have a much more direct approach to what we're looking at here in the picture on the right is the axillary nerve with each of its divisions. It's still a little bit of a deep dive to get in there, but once you pull that up, the reach to the triceps branch is quite simple. And it's immediately above it is the radial nerve coursing over the top. You probably can't see my cursor here.
I'll try to show it for you. Yeah.
Perfect. Yeah, the radial nerve coursing over the top, and the long-headed triceps branch is retracted in there. So you just drop it down. It's a direct. When you go from the posterior aspect of the arm, pulling those axillary nerve branches down and the triceps branches up is a little bit of a tight repair. It's kind of the reverse of what we're doing for plexus injuries when you're doing triceps to axillary, where there's lots of redundancy.
Right. And do you have a preferred donor here, whether it's a teres minor branch or the branch to the posterior deltoid?
So when they're all healthy, I like that teres minor, and in our outcomes, that has been probably the best. There's a really narrow window of efficacy here, and the reason for that is the higher up you get in the spinal cord, by the time you get to the part where you've lost your triceps, the next muscle you lose becomes the teres minor. And from there, you start losing the posterior deltoid. So as you get higher in your C5 injury, you start losing your donors. And so we've gone from a weak teres minor to move to posterior deltoid to using both of those two branches. And in some cases where both of them are degraded, I've done spinal accessory with a graft down to the triceps.
I see. Okay. All right, great. And we touched a little bit about tendon transfer. Do you have, are there certain cases where you'll do both nerve and tendon transfer? Or is tendon transfer?
Certainly for the hand. So our setup typically is do all the nerve work and then give them a full year to a year and a half to get the results. And there almost always is a secondary procedure I'm doing with the hand. Typically with the hand, you're going to get a thumb that folds into the palm with hyperflexion at the IP joint. And that doesn't land a very good pinch. And so you need to get the thumb straightened out, and that can be an IP fusion with your hand surgery colleagues, or you can take one of the FPL halves and swing that around suture to the EPL. But to straighten the thumb out makes the pinch much more effective. Right. The other one you get into is when you've lost all your intrinsic muscles of the hand, is you get a claw. And so very frequently, probably half of my patients, we do what's called a volar plate advancement. So we take the volar plate over the MCP joints and pull that into some flexion. Then when the fingers open, the IPs will straighten as opposed to coming back just to the MCP joint. And so almost everybody needs that. The third thing we reserve is the brachioradialis muscle. I don't like to transfer its nerve because that muscle can be used for almost anything that doesn't fill in.
See.
So sometimes the PIN will extend the finger as well and not the thumb. And so BR to EPL. Sometimes the AIN will flex the finger as well, but not the thumb. So then it's BR to FPL. But that BR is a nice backup tendon to have for whatever doesn't fill in with time.
I see. So you'll save that as a backup. Okay, great.
That's right.
Great.
Did you mention timing as far as when to do it? Is it after 2 years? Dr. Ray showed
Yeah,
that
after at least 18 months, I would give it.
Okay.
Yeah.
Good time.
Yeah.
Do you check an EMG at that point to look for motor unit potentials to suggest recovery, or it's more just by 18 months it's unlikely to get function back and you'll move to tendon transfers?
Yeah, I do, but is it critical? It's probably not critical. I would say by 18 months, you've got a pretty good idea. You've got about 80% of the strength you're going to get. Okay. And so I think you can make a safe decision at that point.
All right, sounds good. And clearly this work involves it's a multidisciplinary approach. Can you talk about your relationship with PM&R physicians, rehab doctors, PT, any specific rehab protocols that you use?
Yeah, a lot of the patients are travelers, so it becomes a little bit difficult to have our own protocol. So what we'll often do is get their therapists on a Zoom call with the patient. and just walk through what the transfers were and what they should expect. The protocols overall are please don't burn through your therapy visits early. Have once a month visits to make sure you're maintaining your passive range of motion and to strengthen everything we used for donors. And then when that movement begins, it's say, 4 months at the earliest, but maybe 6 to 8 if they're an older patient. That's when I want you going and having the therapist help you learn how to move the fingers.
Great, great. And we talked a lot about upper extremity, but can you talk about some work, even if it's more research stage, about nerve transfers for bladder dysfunction and lower extremity weakness after spinal cord injury?
Sure. The bladder dysfunction work we've done has really been a niche population of folks who have like sacral tumors, like chordomas or chondrosarcomas. And the reason that's the population is because we still have lots of adjacent nerves to use. The spinal cord population, you're going to start at thoracolumbar, and so the closest thing we have is lower intercostals, and getting them to reach is a challenge. You have to interpose a graft. For those sacral tumor patients, we have an animal model that we've used quite a bit, and then we've had our first patient a couple of years ago where we used the obturator to the vesicle branch on the wall of the bladder, and it worked. But it's one step in a very complex system. So, for us, we're gonna, relax the sphincter and then contract the bladder and push it all out, and then the whole system fills back up again. For this, we're just generating contraction of the detrusor. And so we still have to worry about the sphincter. And so it's that with an artificial sphincter is what we're doing right now. And I hope to come up with a system that'll include it all in the future. But that one's still a work in progress.
Yeah, not an easy thing with the synchrony there. But along those lines, what would you say, just in looking into the future, what are some areas in future directions for research in this area?
Well, I think moving into other pathologies such as stroke, and people are beginning to delve into that. What can be done with that contralateral C7? There have been some work, and folks have done C7 to C7, which I think for all the reasons it's a wonderful donor or all the reasons it's a bad recipient, because it hits so many targets. And so using that for specific targets such as elbow flexion or wrist extension or something like that, I think will have value. The lower extremity is tough. I would really love to be able to hit a home run in the lower extremity. The distances are so far and the number of branches available are so few. That's a hard target, but I think it is a wide open area for people to venture into with research. And then the same things that apply to brachial plexus injury. If we could keep those muscles alive, then we could get those axons further distances downstream. And so we've been delving into, can we do it with stem cells, putting them in the nerves to extend axons to preserve the muscle, or can we activate those muscles with high energy stimulators to preserve that as the axons are heading to target? All of those things I think will begin to open up new opportunities for us. But it's an exciting time to be in the field because so many things are being discovered so frequently.
Yeah, absolutely.
Dr. Brown, can you comment on the quality of life improvement? Like, it's not just about the surgery and able to complete the procedure with a little bit of a risk, but how much of an impact does this actual surgery have on the quality of life of cervical spinal cord injury he or she is not able to care for themselves, and how much of an impact? I mean, we do have studies, but for your own personal experience, like, can you crystallize that to the learners and the value added that you're doing here?
Absolutely. So it's huge. So you think about what can they do when their fingers don't move? And there's not a lot. So their caregivers will, strap Velcro-based utensil to their hand that they can eat with, and then they'll come and tape that off for them. And, they're going to pass the catheter and they're going to help them feed, but it requires an attendant, essentially 24 hours a day. Once they have the ability to open and close the hands, it really frees them up in a way that we don't see with our brachial plexus patients. The brachial plexus patients always have another limb. And with that other limb, they can do 90% of what they did. But the spinal cord patients, they are entirely dependent, which is why they're so afraid to undergo anything that wraps their arm up for a month, because it's it's sort of terrifying for them. They've already been stripped of all their independence, and then to take any more away is awful. So when we give them their hands back, it really is a life-changing intervention for them.
Last question I had, for the new learners, we know spinal cord injury patients do recover. In an ideal world, in your setting, C6-7 fracture, how do you decide when to intervene, and what is the ideal time point that you decide on? And is it heavily reliant on the EMG data that you get?
Yeah, it is reliant on, so I've kind of moved out over time. And the reason for that is acute injuries will almost always descend a level or two with time. So when they initially come into the ICU, often these folks are on a ventilator because they've lost their accessory muscles, and their diaphragm has to do all the work. It has to strengthen up. And over the coming months, they're liable to gain wrist extension and better elbow flexion and so forth. So I don't want to make any decisions those first 3 months. I used to wait till 6, and now we've pushed it out to 9. I rarely operate before 9 months, simply because the results aren't any better between the 6 months and the 9-month patients. It does start to drop off sometime after 12 to 15. When we get to 18 months, they're definitely weaker than they are at 9 months. But the 9 to 12 range seems to be just fine for these patients. And so for that reason, I don't want to interrupt anything that's coming. And the reason I'd say that is if you gain something, so if they gain finger extension with time, they will have independent finger extension. When we do supinated PIN, it is one gross movement always. And so spontaneous recovery is always better than reinnervated recovery, but reinnervated recovery is certainly better than no recovery at all. So, 9 months is my rule of thumb now for the ones that are denervated. If they stimulate beautifully at the 9-month mark, if I can put that stimulant in the back of the arm and watch all the fingers go up, and if I can snap their fingers and get a tight Hoffman's, then there is no rush. I can tell them, go talk to the family, come back next year. We can do this anytime. You'll be just fine. It's better to catch them early because folks don't want to, they kind of get into their habit. They've learned to live with it. They almost don't want to change things. So I'd rather intervene within that first year than wait till 5 or 10 years later.
Makes sense. How about any experience with nerve transfers for other spinal cord pathologies like demyelinating disease, like a transverse myelitis?
Sure. Most of those were dealing with spastic entities. An MS I found to be a challenging population. And I don't know if that's just my personal experience or others find the same thing, but the engagement in therapy, their follow-up, their following all the recommendations we have, it's in general a more challenging population.
Okay.
Stroke is more reliable, and spinal cord injury is pretty reliable, but MS has been tough.
Sure. And I think just to kind of conclude things, it would be great if you were willing to share with us how you got interested in nerve surgery to begin with, and especially how your practice has incorporated nerve transfers for spinal cord injury.
Sure. It was a little bit of a fluke. I went to a medical school that had no neurosurgery program, and I found out very late in the game that if you needed to get neurosurgery, you needed research. And so I ran around my medical school looking for somebody doing something neurosurgical, and I came across a plastic surgeon doing brachial plexus work. And I thought, even though a plastic surgeon was doing it, clearly this is neurosurgery. It is the nervous system, and these are nerves, so how could this be plastic? So I got a project from Dr. Terzis about nerve root avulsions and how you might be able to reimplant a nerve root, and I just became fascinated with it. And then over the years, and went to a residency program that didn't have much nerve reconstruction, but kept, every time these pathologies would come across where somebody's paralyzed, I thought, could a nerve transfer or a nerve reconstruction fix this? And so that interest remained through residency. And so I decided afterwards I'd go ahead and do a fellowship and see what we could do with it.
Wonderful.
Thank you.
Thank you.
It was a wonderful talk. Thank you for all the insight. Definitely very, very helpful and clarifying lots of questions for early on learners. And definitely Jared and myself learned a lot. So thank you so much for your wonderful pros.
Yeah, thank you guys. And thanks for doing this. This is a great idea
yes,
to get people on record for this stuff. So yeah, appreciate it. You guys have a good evening.
All right.
Thank
Thanks
you.
a lot.
You bet. Bye-bye.
Jared.